Now, I have a great deal of pleasure as well to present a perfusionist, David Fitzgerald. Mr. Fitzgerald is Chief of Cardiovascular Perfusion at Inova Fairfax Hospital. He's the ECMO coordinator. He has been president of AMSEC, the American Society for Extracorporeal Technology. He is very experienced with a variety of ventricular assist devices. I'm pleased that we now have David on our board of directors of FaxCare. He has contributed to our past meetings, importantly, on our program committee, and it really gives me a great deal of pleasure to present him. He's going to continue the discussion. David?
Good morning. Thank you, Dr. Kotz. It's great to be back here. I got to tell you, as a perfusionist who spent the first decade of his career confined in the operating room, what we're seeing with the growth in mechanical assist and ECMO is that perfusionists are finding themselves spending a considerable amount of time in the intensive care units. And so I think that's really what lends to the beauty of this multidisciplinary conference, is that perfusionists get a chance to work and collaborate with some of our critical care colleagues, you in the audience. So I thank you for the opportunity. I have no disclosures to report. So Dr. Half spoke to you about some of the durable devices and certainly scared the pants off of all of us with the complications that can ensue with patients, not only in the hospital, but in the community. And so I want to shift gears just for a few moments and spend a little bit of time looking at short-term devices or those mid-term devices in a specific indication, in this case, right ventricular failure. And so as you see here in this illustration, you have left ventricular assist device insertion on the right-hand side. And I have a pointer here. I apologize for only pointing to one side. But as that, you can see here on the left, your patient presents with high left ventricular pressures, increased right-sided pressures subsequent to pulmonary hypertension from the LV failure, low cardiac output, hepatic congestion. So when we put this device in this patient, you can see here that left ventricular pressures are decreased. We increase cardiac output. We think we've done a great job. Let's close the patient up, get him to the unit, and get the patient out of here. And so sometimes it's not always that easy, and I'll show you. But you can see here on the short axis of the TEE, you have your RV and your LV. This is at no flow, but as we increase the pump speed, you can see here that septal wall, that ventricular septal wall begins to shift, collapsing, well, not necessarily collapsing, but decreasing the size of the LV, and therefore subsequently increasing the size of the RV. And so what happens on occasion is that even in patients where we don't suspect there to be right ventricular failure, you'll see an outbowing of the RV here. So we're changing the geometry of the right ventricle, in a sense kind of losing its fulcrum. At the same time we're doing this, we're increasing the cardiac output. So the blood flow that gets sent back to the right atrium is now could be at 4 or 5 liters instead of the 2.5 to 3 that the patient presented with. Couple that with some leftover pulmonary hypertension and then some of the RV distension from the change in the geometry of the right ventricle, we start to run into a situation where perhaps this RV isn't going to be able to successfully fill the LV. And so we look at some of the definitions for RV failure, and these are the common definitions that are out there, 3 of which are used by the Intermax repository for long-term ventricular assist. But you can see here the need for inotropes greater than 14 days, inhaled nitric oxide for greater than 48 hours, if we actually have to go in and place a right ventricular assist device, and then if they're discharged from the hospital with inotropic support. Why is this so profound and the complications so severe? They might not be as acute as some of the issues that Dr. Half raised, but you can see here that some of the subsequent events can be very profound. Just looking here at length of stay, these patients that experience right ventricular failure, whether or not they get a device versus inotropic support, are in the hospital at least another week. Looking at the cost breakdown, if you go ahead and do put in a device, that's the additional costs that are realized. And then mortality. Mortality rate doubles in this sick patient population as opposed to those folks that don't have or experience right ventricular failure. Looking at a retrospective review here, I believe this was from the Johns Hopkins program published just earlier this year, looking at these are all complications, the percentage of complications over a 12-year period of device insertions, both HeartMate XVE and HeartMate 2. And you can see here, it may be tough to read, but the number 3 complication at 26% was right ventricular failure. So it happens more sometimes than maybe we led to believe, 1 out of every 4 patients at some programs, and even higher in some others. This data is from the HeartMate 2 investigators when they went back and did a cross-section of patients with RV failure. You can see here, and I apologize that this didn't come out as clear as it did on my laptop the other day. But you can see here 6% of all patients had a right ventricular assist device inserted. Inotropic support, either early or late, was 7% and again 7% respectively. And so therefore, you can see here that, again, that coincides with the statistics I just showed you about almost 1 out of every 4 patients experiencing some type of RV dysfunction. And you can see here on the right with the Kaplan-Meier survival curve that it has a significant impact on long-term survival as well. And so I think the idea here is that we can't always control which patients are going to experience RV failure. Sometimes they present to us in acute cardiogenic shock with biventricular hypokinesis, but what we can do is find ways of managing this, identifying it, and treating it sooner. And you can see here the devices that they chose to use, and I'm going to go over just a few of those in the interest of time. Can we predict RV failure? So can we look at a patient, determine whether or not they're going to experience any RV dysfunction post-bypass, post-operatively? And this article was published from University of Michigan very recently, looking at nearly 200 devices retrospectively that were implanted, and they assigned risk scores. And you can see here that the risk scores that they used varied from 4 points down to 2 points, looking at preoperative vasopressor, creatinine, elevated creatinine, bilirubins, and NASTs. And so they assigned a point scale, and what they found that looking at your odds, if you had a total cumulative point score of 4 to 5, you are 3 times more likely to experience RV failure. And then, more importantly, if you had a score of 5.5 points or greater, you had a nearly 8-fold increase in your risk of RV dysfunction. This is one of many treatment algorithms. I'm sure if you're a mechanical assist device center, I don't know if you would have this necessarily in paper, but everyone goes through the progression of how we treat it when we're in the operating room. And you can see here, we would start with some pacing, looking at our decision tree here if we needed to add volume, or if we're already distended on the right side, looking at contractility, are there inotropic support mechanisms that we can use, looking at position, using the TEE to determine the position of the ventricular septum. Maybe we have to come down on flow a little bit in order to swing that pendulum back the other way. And when all of those fail, we go towards trying to reduce pulmonary vascular resistance, and if that doesn't work, then we revert to the right ventricular assist device. And this is a decision that has to be made very carefully when we're in the operating room. We don't want to ignore some of these parameters, send the patient over to the unit and have them struggle. That's something that I think we've learned in, more recently in the literature, that patients fared better when they had an early RVAD implanted rather than struggling in the unit for 12 to 24 hours. So one of the devices that we can use, obviously, is the CentraMag. It's a short-term device. It's actually FDA approved for RVAD support up to 30 days. It's magnetically levitated, so it doesn't have any contacts or bearings or points where it would induce increased hemolysis. This is probably a device that a lot of centers use. It provides up to 10 liters of support, not necessarily meaning that you would put 10 liters of support on your left ventricle, but obviously provides the opportunity to do so. Another such device is the Tandem Heart, and I think we don't use many of these devices at my center, but I'll tell you one of the attractions of using this device is that they have proprietary catheters that you can insert percutaneously. So you're not having to do a direct cannulation for an RVAD where you would otherwise do an RA-PA cannulation. You can insert 2 femoral venous catheters and then advance one up into the pulmonary artery, therefore creating right ventricular bypass. We can also look at some I'd like to call them mid-long term support devices. The one on the left here is a paracorporeal device, the Thoratec PVAD. It could be used as a dischargeable device. So in some cases, if patients cannot be discharged to home on a short-term device, you can transition to this or one of the implantables. On the right here is the Abiomed ventricle. From my understanding, currently you cannot still be discharged to home on an Abiomed ventricle, although they do have a portable portable pump console, but you're still confined to the hospital campus. And then, if the right ventricular failure was either long-term or we knew there was right ventricular failure going in, obviously we would be looking at biventricular implantable devices, or at some centers that are aggressive with total hearts may choose to go that route, but this is more of a short-term solution. You can see here the X-ray of this is a HeartMate 2 device, and you can see the catheters actually for the RVAD. This is a CentraMag RVAD that's been inserted. Probably a better view here from CT scan. This is your inlet cannula from the right atrium, and you can almost make out in the back the PA catheter, again, in tandem with a implantable device. Some of our clinicians at my center and the VAD coordinators came up with a fancy acronym in terms of how they manage or help to diagnose. So you have these great laboratory assays that would help you determine whether or not there was right ventricular long-term failure, but how do we diagnose it in the acute sense? And so they came up with this acronym, SHAB-DORC. These are all the conditions that may potentiate a low PI or a flat waveform when you have continuous flow pumps. And so you can see here one of their indications, obviously, right heart failure here. So I think we're out of time here, but thank you so much. And I put this slide in. I happened to go to the ball game with my son yesterday, and some people mentioned the Mayan calendar and the end of the world, but the end of the world, I think, was just made apparent yesterday. For those of you that aren't familiar with the baseball team, they have the President's Race every seventh inning, and Theodore Roosevelt won for the first time in the team's history, and so. I thought it was he got more of an applause than they did at the end of the game when they finished off the season. So, thank you.
Dave, thank you for the update on the Nationals. A number of us in Washington have been following that race, so that's excellent to hear. This has been quite a morning. And what we have planned now is an audience panel discussion. And I'd like to invite our presenters up to the podium. And I have one additional member of the panel to identify and to introduce to you, and that's Stephen Sims. Steve, why don't you come up as well so they'll see you. As you know, we feel it's very important that cath lab professionals are part of our multidisciplinary team these days with the merging of specialties. Steve Sims is a cath lab professional. He's patient care director of the cath lab and EP lab at the Virginia Hospital Center. He has extensive cath lab experience and major management experience in cath lab. So, Steve, welcome to the panel, and we appreciate your insight into these issues. I guess Dr. Naidu may have had to leave, but fortunately we have Dr. Haft and David Fitzgerald to answer questions about ventricular assist devices. And Dr. Fine has told me that he may need to leave early, and so I'd like to start. We have two microphones, and we want you to step up to the microphones and ask your questions, but as you start to come up, I have a first question for Dr. Fine. And it's a fairly simplistic question, and I think you addressed it, but I think we all deal with the question of should we give bolus therapy or continuous diuretic therapy? Do you give 40 of Lasix, 80 of Lasix, or do you start an infusion like 5 milligrams per hour, 10 milligrams per hour? And the other thing is, to add to that question, some agents are used, as we all know, to help induce the diuresis. Sometimes we give Ivryl Diaryl, sometimes we give metolazone. And so, Dr. Fine, I appreciate your insight into some of these issues, which I think we all have make decisions about on a daily basis.
Sure. So the first question is the use of a continuous versus bolus. You know, one might think that the continuous is a little bit more predictable because you can dial it up, but the physiology changes in real time, and so it turns out that it may not be as predictable as one might think. I don't think it makes much difference, at least Mike Felker's study in heart failure and many others are really equivocal about whether one is better than the other. I don't think there's been a study that's convincingly shown that one is more beneficial. The problem you do have with the bolus therapy is you don't know how your patient's going to respond after that first dose, so that you could get in trouble if it's too vigorous. But again, if you're in an ICU setting, you're watching the patient. If you have too vigorous a response, you give fluids back. You know, there are times when I would give a bolus. You know, my acutely decompensating patient, where, you know, they're on the verge of getting intubated, maybe they have a BiPAP on, a non-invasive ventilation, and you really want to get fluid off fast. You know, I just go for as big a dose as I can give them of a loop diuretic, 160 of Lasix, and they declare themselves. They don't respond to it. It's time to bring in a machine to get the fluid off. So in the situation of someone who's acutely decompensating, I kind of like a big bolus up front, whether you want to maintain them with a drip or not. At least Felker's study would suggest didn't make a big difference. Regarding the use of Diaryl or metolazone, what I didn't really point out on the slide where there was that braking effect, was part of that effect is actually related to distal nephron. At least when you're on a loop diuretic, the distal nephron will insert more sodium chloride channels into the apical membrane, and you start holding on to more sodium distally, and that's driven in part by aldosterone and these other hormones that are being turned on when you start to use a diuretic. And so those sodium chloride channels, which are the ones that are thiazide sensitive, are now they've ramped up their work. So now when you add a thiazide on top of things, you can get a whopping response. To use it up front, there's probably not a great utility unless someone is already on a loop diuretic and they've chronically been on a loop diuretic. Then you expect that distal nephron has ramped up sodium retention. Adding a thiazide, either metolazone or Diaryl, whichever you prefer, will give you an extra bang for your buck. To use both up front, again, it may be overkill, but in someone who you've achieved what you might consider a maximum dose of a loop diuretic, whether it's 160 milligram of Lasix twice a day, whatever that number is that you like to think is maximum, somewhere between 240 and 360 a day total. If they're on that and that you're not getting an adequate diuretic response, then adding a thiazide would be your next step if you're going to use a diuretic, because you're going to inhibit at another point in the nephron. The only other diuretic I might consider using is if they're starting to evolve an alkalosis, then using a carbonic anhydrase inhibitor, so acetazolamide. That's the one time I might use acetazolamide. It's not a very good diuretic, but it does attenuate the alkalosis that evolves.
Well, thank you. That's very helpful. Dr. Rebabor is still here. Why don't you come up aboard too? I want you to be part of our panel. I actually have a question I wanted to ask you as well. Why don't you join the panel? Great. Are there any other nephrology issues that come to mind immediately that you would like to address? Dr. Whitman.
Dr. Fine, I apologize because I missed your talk this morning, and maybe you addressed this, but a lot of times you're faced with a person whose creatinine's rising, their BUN's rising, but all in all they're doing well and there are no absolute indications for dialysis. On the other hand, they are fluid overloaded, and the argument goes, well, we'd like to take fluid off, but we certainly don't want to precipitate the need for dialysis, so I want to hold off and I don't want to dialyze this patient, and I'm going to try to tiptoe through this problem and avoid dialysis almost at all costs because I don't want to make them dialysis dependent. Is there any truth to that?
So dialysis dependence is a tricky one. I think that most patients, when there's acute kidney injury, if you can get them, as long as the acute kidney injury isn't from some atheroembolus or severe hypotension for a prolonged period of time, my expectation is they're going to recover. And if I have to put them on dialysis a few extra days to save their life, which might be the case here, I'll do that. I don't think that putting someone on dialysis reduces your ability to recover from acute kidney injury. I think that's a really important point. Maybe I might be wrong in some cases, because when you put them on dialysis, if you do bad things to them, like drop their blood pressure continuously and put them into an arrhythmia and then they hyperperfuse their kidney, then there's that chance. There are people that never come off dialysis. But I don't believe that putting them on dialysis, if you do it appropriately and you're watching the patient closely, is going to affect their ability to recover. And I did get into this, the idea of if you've got just volume as an issue, the diuretics can often get you in trouble. And that may be a time when putting someone on, using ultrafiltration. I do want to clarify, I got a number of questions, and I didn't probably make myself clear, because a lot of people ask me about the sort of aquapheresis, and that is pure ultrafiltration. Okay, I think what I was sort of thinking of was the patient I'm seeing with acute kidney injury, where I'm probably using a continuous dialyzer and just doing ultrafiltration with that, maybe dialysis at the same time. So you can do ultrafiltration with a regular dialysis machine, you can do it with a CVVHD machine, a CVVH mechanisms, and you can use these newer devices that I think most places aren't using, but there was someone in the audience who they actually have these aquapheresis, small little devices in their unit where you don't need a real dialysis catheter, which down the line may be where we're going with that exact patient. That's the exact patient that I think may actually benefit from ultrafiltration over using diuretics till that last point, and then the person seizes because their sodium goes down to, 120 or the other direction, depending on how much water you're giving them. So I don't think it affects renal recovery, if that's the main point of that question. You put them on dialysis. The only risk of dialysis in my mind is putting the catheter in, and the catheter then getting infected. It's a big risk, but relatively, but...
Yes, sir.
Gene Heroes at the Jefferson. I have another question regarding to the acute renal injury and after the heart surgery. So if a patient had a left ventricular dysfunction, it's easy to treat. Usually put on some device in, like an impeller, or put on the inotropes and easily treat and increase the pressure. However, we have a lot of people who has a very difficult to manage, which is right ventricular associated acute renal injury. So talking with people had a heart surgery, came into the unit, and we did marginal urine output, we did the echo, showed the isolated right heart failure, and the CVP is a 15, 18, and talking with the cardiologist, feel the heart. And talking with the heart surgeon, don't put those water in, is the patient going to pulmonary failure, pulmonary edema? And then talking with a nephrologist about you will observe. And then the intensivist ended up with a reduced pulmonary vascular resistance, put on the Miranon arm, and the next day ended up with much blood pressures because Miranon decreased pulmonary artery pressure. However, the increase the systemic resistance and decrease the systemic resistance and reduce the blood pressure, put on the pressors on. And then following days, the nephrologist came back, the patient, the pressors, you guys not good. And how can treat the right ventricular associated acute renal injury? This is my question.
Is that for me?
Yes, I think so.
The fact that you have 4 people in the room with 4 different pins means we actually don't know what to do. And sometimes we can't do anything. I think what you do is you have to compartmentalize it. So, for example, I don't quite understand the VAD the way you guys do. And so I talk to Glenn and I talk to Nevin and I say, hey, I'd never actually heard about this right ventricle sort of failing when you put the LVAD in. I've seen it, but I didn't realize the mechanism. That was very interesting to me. And I was like, okay, now I can go tell my fellows something. They'll think I'm really smart tomorrow. But it's got to take collaboration with people who are mature and who can accept that maybe they're not right, and then come up with a plan where you intervene on each issue. So if I know that, you tell me you think that getting a better forward flow is going to work. We know that VADs have been shown to improve renal function. Get better forward flow. I'll come in and say, if I can do that at the same time, reduce my right ventricular pressure and my CVP, I'll do that. Maybe that will require putting an RVAD in. That's something I'll ask you. I'll say, hey, do you think you can get this pressure down a little bit on the right side without dropping the systemic pressure? And we sort of get into these, you do one thing and something else goes out, and often we just don't have the answer. So I sort of say, okay, here's what I can do on a renal side. I can get fluid off. I can make sure that if you diurese them and the sodium goes up, it doesn't go up too high. I can do my thing. I can make sure you don't die from hyperkalemia, you don't have electrolyte problems, you don't get too acidotic, and I can get some fluid off your patient. You need to make sure that the pump works. And I think that that's the best we can do at this point. We don't actually have a good understanding, but I think that sometimes in those situations, you try something, you see what happens, and hopefully that's something that won't kill the patient, and that you've got time to judge whether you can shift your focus. I don't have a better answer than that.
I think that's a great answer. I wanted to shift to anticoagulation, but did you want to ask, go ahead with your question.
Well, the one question I had is, in your talk regarding acute kidney injury, risk factors, as was stated earlier, our patients are getting older, they're getting sicker. We have a lot of patients with high creatinines, and our surgeons are starting to use phenaldipam, okay? And you didn't mention that at all. And, the issue is they're on phenaldipam, they're coming out on 2 other pressors. Is there any data to support the use, really? And if we are going to use it, should we really stop it at 24 hours, which is the only one study that showed any sort of benefit, or do we continue it longer than that?
Well, that's an interesting question. Go ahead.
I don't know the phenaldipam data very well, and when I've looked at it, I haven't been overwhelmed that it does much. I think most of the things we've done have not been good at preventing renal failure. I don't think it showed too much detriment, and if you can monitor it and afford it, it probably doesn't hurt. But I don't think the data is strong enough that nephrology. We sort of say if we're not using it, probably hasn't made it to mainstream yet. There really hasn't been much in the nephrology world about doing that. I think one of the important points is I didn't show the graph, but the problem with people with chronic kidney disease, and that's where you're seeing most of this, is that they really require higher blood pressure or mean arterial pressure to perfuse the kidney, and most of it is just renal perfusion. And the maps that we're targeting, like 60, because that's what the brain needs, is probably too low for the kidney. But targeting 70 comes with all the cost of using pressors and other things. So we're in a tough place.
It's interesting you brought that up because, we focus on mean arterial pressure as well. But we also try to tank the patients up as well. And, your talk regarding the CVP and trying to keep that lower to improve actually that renal perfusion kind of makes a lot of sense.
Well, thank you. I want to shift, if we can, to the question of anticoagulation. I think we all deal with a number of issues. Thank you so much, Derek. Anticoagulation from a number of standpoints. We've talked about VADs. We talk about ECMO. We're going to be talking about valves. But since we have discussed point of care technology, I'm also interested what you do in the cath lab, Steve. Maybe you could just start out and tell us in the cath lab, what sort of point of care technology do you use to look at anticoagulation? And then I was going to ask Dr. Rebabor to tell us his recommendations in the ICU. Do you use standard PT, PTT in the cath lab? Do you measure, or do you go further? How do you monitor patients in the cath lab?
In the cath lab, we do look at PT, PTT, but our main standard is our anticoagulation time, our ACTs, which we try to keep with any procedure that we do, stenting or valves or anything over 200. So it's a nice quick test that we can get back in. It's done right in the room that we can get back within 2 minutes.
See, that's very helpful because that's really an extension of the operating room, isn't it? That's
Yes,
what we use when we put patients on cardiopulmonary bypass. So, Dr. Rebabor, there are a number of possibilities at point of care technology. Obviously, if somebody's bleeding or we have a question, we like the result back as quickly as possible. Can you tell us your thoughts about point-of-care monitoring for anticoagulation?
Yeah, it's actually one of the biggest tests that we do in the ICU because of the impact on bleeding. And most of the protocols that we have revolve around looking at the PT, the INR, the PTT, and the platelet aggregation assay. So we have a way of objectively quantifying what percentage of the platelets are working. And this is really of a lot of relevance with patients who are on Plavix. Typically, as you know, in CT surgery, we usually hold the operation for 7 days before. But a lot of the platelet aggregation assays show that even if you did do that, there are some patients who are resistant to Plavix, so you didn't need to wait that long. And there are some patients who, even in spite of the fact that you waited that long, they still have a qualitative platelet dysfunction. So when we get patients coming out of the OR who are bleeding, we get a PT-INR right away if they're normal. We look at the difference between their platelet count on arrival in the ICU, and we compare it to the preoperative platelet count because of the HIT syndromes. And if there's been an absolute reduction in the platelet count by more than 25%, we will transfuse platelets. If it's a renal patient, for instance, who we've dialyzed, or if there is bleeding postoperatively in a renal patient, we will give DDAVP as well, because that improves their qualitative platelet function through the von Willebrand factor that's given.
How often do you recommend use of the TEG, thromboelastogram?
It depends. We don't use it a lot. I think it varies on the interaction between the intensivist, the perfusionists, and the lab, and how you're going to interpret that test in terms of applying it. So I think we don't use it that much.
So let me then open that up to Dave Fitzgerald and Jonathan Haft. David, from a perfusion standpoint, obviously you represent the transition from the operating room to the ICU. And, you know, what is your thought about ACT, monitoring these patients as they come into the critical care unit? And then I'm interested in Jonathan's thought as well.
So for cardiopulmonary bypass, we use the ACT almost exclusively, and we set our targets and our ranges in terms of what's safe to conduct cardiopulmonary bypass. However, when we get into the intensive care unit, especially with patients that are on ECMO support, for instance, we'll revert to a PTT assay as well as a anti-factor 10A, and that'll probably be some of the topics that we'll be touching on this afternoon with Dr. Lynch and the ECMO group. But in terms of the ACT, what we find is that, especially at lower heparin doses, there is a significant amount of variability, not only between machines. There's 11 devices out there. As far as I know, there's 11 devices out there, and there's been some studies performed to show that each one of them is variable from another. And then user manipulability, making sure that you fill the chamber up manually to the proper prescribed amounts. And so sometimes there's some variability with users as well. So we've reverted to the PTT and then have always intermittently used the anti-10A to ensure that we weren't getting a falsely elevated PTT from something such as, you know, hepatic congestion or lupus anticoagulant.
Helpful. Jonathan?
I don't think I have any great wisdom to add to this. We don't use the thromboelastogram for anything, for cardiac surgery or for ECMO. We did dabble with it in cardiac surgery and did not find a great correlation between perceived coagulopathy and what the TEG interpretation was. My experience with post-cardiotomy bleeding, usually it's one of two things. It's either a proline deficiency, and the patient just needs to have the hole in the blood vessel fixed, or it's a diffuse coagulopathy that is often not detected on a PT, PTT, or even a platelet count. Patients are just bleeding from raw surfaces, like the endocarditis case that you described in the opening session here. Oftentimes the PT, PTTs are normal, ACTs are normal, but the patient's bleeding like hell. And in our experience with TEGs, those were often normal too. So I think we need better tests.
Let me just ask a quick question. This is sort of what we say fundamental question to Dr. Ribabor, but I'd be interested in the panel. You know, from the very beginning of critical care, medical school, whatever, we talk about the hematocrit and we talk about the hemoglobin. And the more that I get into it, the more I appreciate that even though we tend to use them interchangeably, that there's some important subtle implications. Oxygen carrying capacity for the hemoglobin and just volume of packed cells and blood loss with the hematocrit. Now, you can use either, and I know that we do use either, and we have preferences. But since I got a panel in front of me, I just thought it'd be an interesting conversation. Dr. Ribabor, do you have a preference? I think point-of-care technology, the hematocrit is fast. But tell me your thoughts about that.
You know, you can't really win a discussion on either one. But with the assays that we use, we have a specific cartridge in which we get hemoglobin and hematocrit. What we've found out is more relevant is actually the trend that occurs over a period of time. We discovered this because we have a protocol in which we do arterial blood gas analysis every hour for the first 6 hours. And lo and behold, we then get a hemoglobin and hematocrit with it. And we correlate that with what they get from the lab. So in that time frame, it's not really so much the blood volume that we're really looking at. It's really a quick determination of whether or not they're bleeding or not and the dilution effect. And even that is indirectly not accurate because there are new assays that can actually quantify the blood volume and the plasma content that are just coming out now. And we're really looking at that towards next year. But I don't really see any preference for the hematocrit versus a hemoglobin in the decision-making analysis in the fresh post-open heart surgery patient.
Well, I appreciate you saying that because I think that's a general consensus, but there are discussions to go back and forth. Yes, Dr. Levy?
Your point about the coagulation testing and its inability to actually help you predict or manage bleeding is a very interesting and important point that I just want to further elaborate on. And the reason why, because all those tests, none of them pick up platelet dysfunction. Furthermore, all those platelet function tests like Verify Now and all the other fancy assays are not helpful in dilutional thrombocytopenia. Preoperatively, a patient's on a thienopyridine like clopidogrel, prasugrel, ticagrelor, they can be very effective at determining whether you have a defect or not. And with clopidogrel, it's particularly important because based on the cardiology literature, they may be a 30% variability in terms of responsiveness. But I think it's really important, and that's the problem with all these coagulation tests. The thrombolastography and thromboelastometry, which is the ROTEM testing, the new kind of TEG, if you will, I think is useful for bleeding because it tells you a little bit about the global hemostatic function. The problem with those tests is fibrinogen overdrives any clot. So you see a normal test when there's normal fibrinogen. And it will trump for platelet dysfunction because right now in Europe, in the States, we're doing studies looking at fibrinogen as a therapeutic intervention for coagulopathy. So all these points are really important. And it really sort of is the issues that we don't have good coagulation testing, which makes management really perplexing. The advantage of the TEG and the ROTEM, if you have a normal tracing and you're bleeding excessively, you probably have a hole. And it's a useful test. If you don't have a TEG or a ROTEM in the Planet, I like to use a very fancy test called the Lee-White clotting time. Tell them what the Lee-White clotting time is. You put blood in a red top tube and you see if it clots. If it's not clotting in the tube, it's not clotting in the patient. But if it's clotting in the tube, usually a normal time is about 7 minutes, like a bleeding time. I think it's a useful adjunct because if it's not clotting in the tube, it's not going to clot in the patient. But the point is that correlating the two is really complex and problematic, and we need much, much better tests. So I think your point was really important, and I think again, the perplexing management of these patients post-op. Getting back to ECMO, I wanted to ask you a quick question. One is that when you monitor anti-10A levels in ECMO, what level do you target? And also, my understanding is the UM group uses, also you monitor antithrombin and you keep it at 100% activity. Is that correct? In adult, not pediatric ECMO, but adult ECMO. So the question is, what anti-10A level do you use and what antithrombin concentration? Do you monitor it daily? Do you monitor it twice a day? How do you monitor your ECMO patients?
No, no, and no. We just monitor the PTT. And if they're bleeding, we have a very low threshold to just stop the anticoagulation.
But for I think one of the questions is the perplexing point is what antithrombin level. We keep a level of about 0.2 to 0.3 anti-10A. A lot of hospitals have gotten away from partial thromboplastin or PTT monitoring And there's a lot of variability across the planet, whether you use an ACT or a PTT to monitor anticoagulation. But I'm sort of interested because I think it's a great focus. We need to better figure it out. So there's so much empiricism in the management. You mentioned anti-10A, but we keep a level of 0.2 to 0.3 for ECMO, which is an ACT of maybe 180 to 200 approximately. But I think it's important food for thought. Thank you.
Our range for anti-10A can be anywhere from 0.3 to 0.7, and that we stratify it based on patient presentation. So if this is a fresh...
What antithrombin level do you guys keep, or do you don't bother?
We do antithrombin function more in pediatrics than we do adults, so we don't have a formalized process for AT3 function, but we've had levels as low as 60% and not treated. With regard to anti-10A, we run a range from 0.3 to 0.7, and again, I think that's based on whether or not you have a fresh post-op cardiac patient versus a respiratory ARDS patient that doesn't have any adhesions or active bleeding, and so we're very conservative with that. And if we do have a fresh post-op patient coming out of the OR and they're bleeding, we'll go several hours without heparin, and we'll risk compromising a circuit if it means that they're not bleeding profoundly.
And platelet count, what platelet count do you keep during ECMO?
Yeah, it's a good question. I guess it depends on which surgeon's on call that evening. I think we try our best to be somewhere, if I had to shoot from the hip, 75,000 to 100,000. But we've had platelet counts as low as 50,000 and haven't treated.
Microphone.
Could I add something just quickly on the?
Yes.
You mentioned something about the platelet aggregation assays. In 2004, when we started the program, we looked at all of the different platelet aggregation assays. They all looked good. But the problem was there was no extrapolation of at what number do you bleed and at what number do you not bleed. Mm-hmm. And so you couldn't really say. So what we did was we didn't change any of the practices. We decided we would do what we normally do, look at the PTs, INRs, and adjust the way we normally do, and then do a retrospective review and look at what number did the platelet count correlate with a significantly reduced or increased proportion of bleeding. And what we found out was that with a platelet, you would need a platelet aggregation assay of around 70% going into surgery, because we were measuring the platelet aggregation assays pre and post-op. And we found out that it dropped by about 10 to 20% just coming off pump. So somebody could come with a platelet aggregation assay of 70% and you'd think they're fine. And the post-op platelet aggregation assay would be 50% and you're transfusing platelets for patients that were on Plavix. So when we got that information, then we said, well, let's do this going forward prospectively and not operate on anybody whose platelet aggregation assay is less than 70%. And that led to the realization that there would be patients, for instance, on Plavix whose platelet aggregations were 90% chronically, who would go for surgery and not wait 7 or 10 days and not bleed from a platelet dysfunction. And there'd be patients that we'd waited 7 to 10 days and their platelet aggregation was 30% or 10%, who would have actually already bled. So it really requires taking those assays and then looking at your program and looking at where the bleeding is, and really we had to sit down with the blood bank and then get these linear correlation values and look for an R value that was close to 1, and then find out statistically where the significance was, and it varies, but what it led to was a massive reduction in blood utilization products post-operatively in patients. And it also required, having conversations with the surgeon, say, could you just delay this operation a couple of more days, or saying he's going to bleed, because as we all know, with the platelet, bleeding post-operatively, the only treatment is to transfuse platelets if that is the cause. So it's not uncommon to use all the platelets in the hospital for someone who's bleeding from cardiac surgery and the PT is normal. So the point of care testing does help, because when you've got a normal PT and a normal INR, sometimes we'll look at the bleeding test you were talking about and the bleeding times. We do it with the mediastinal chest tubes. So we just lift it up and we see whether there's any clots or is it thin blood. So we know that there's no clotting function. It's patently obvious. And when we transfuse the platelets, you can actually see clots forming within the mediastinal tube. So you know you're on the right track. So I do think there is value to looking again at these platelet aggregation assays because they don't have any protocols. It's not like, giving heparin and looking at a PTT. They just give you a number, but it doesn't correlate clinically with what's going on with the patient.
That's very helpful. Now, I want to point out that at 3 o'clock today on our program, Dr. Gerald Levy, who you heard from before, who's truly a world-renowned expert in hemostasis and all these issues, is going to talk about management of bleeding after cardiac surgery, and I suspect, Jerry, you're going to talk about some of this evaluation as well. We have 2 additional questions. We want to keep them as short as possible because we're running late.
So thank you, Dr. Katz. I want to express my appreciation for this interdisciplinary conference that's so educational, and you are definitely a pioneer. So my question is directed towards the intensivist on the panel. I'm really glad to see that you're here. Again, my name is Denise Sabatino. I'm the nurse practitioner for Cleveland Clinic, Florida, and we've recently instituted a closed ICU program run by the intensivist, which comes with all its challenges. So let me see if I can succinctly and quickly state my question. Our challenge has been, how do we implement the interdisciplinary, multidisciplinary rounds and make sure that every voice is heard so that we can optimize outcome? Interdisciplinary rounds need to happen in a short fashion. All disciplines cannot be there for the entire duration of the day. What we've done is the intensivist goes with our residents and sees the patients at the point of care, and then a nurse practitioner with a team consisting of a pharmacist and a physical therapist and a psychologist and a case manager, and we have a multidisciplinary team. We walk around individually, and it takes maybe 30 minutes to see every single patient and make sure that those disciplinaries get their voice heard and orders get implemented in a timely fashion. I was wondering if you do anything different at your facility.
Let me just say that that's a tremendously important question. And at 12 o'clock, our symposium is really going to address the answer to that with our multidisciplinary panel, led by Mary Zellinger. But if you want to give a quick answer to it, that's fine. But that's a tremendously important question. We're going to address that for an hour starting at noon. Great. So do you want to say anything differently for the moment? And then we'll see what our symposium says.
Just 1 minute. I think you should time the rounds based, in the morning, the operations are going to start between 7:30 and 8. So it makes sense to really get everybody in the team around at 7:15. And I think it's critically important to have the pharmacist, the respiratory therapist, the CCRNs, the PAs, and in the unit at 7 o'clock in the morning, and to try and finish everything between 7 and 7:45, depending on the timing in your case. And then on the rounds, to make sure that everybody who's there presents. So it's not one person leading the show. So the respiratory therapist has to present. The PharmD has to present. It's not just, is there anything going on with pharmacy? He has to go over the drugs and the interactions and the implications based on the data they've received. And then to keep it short and brief. So I won't say more than that.
That sounds excellent, and we're going to go into detail at our noon symposium. Finally, Dr. Whitman, a short question.
Dr. Hoff, you raised the issue of ventricular assist devices and anticoagulation, and that 20 to 30% of people are going to bleed. Actually, 20 to 40% of people are going to have GI bleeds. What you didn't talk about is how, and then prior to that, you talked about the problems that 10 to 20% have issues associated with thrombosis. So how do you handle the person who comes in with a GI bleed who you can't anticoagulate? What are the dilemmas that you face?
It really is a tough. Problem with VAD therapy. We have found from our own institution that having a GI bleed is associated with a future thrombotic event. Others have shown that GI bleeding is not associated with major mortality, but we've found it's associated, and obviously the explanation is that you're holding their anticoagulation for a period of time. Usually our management strategy is a GI bleeder comes in, you hold their anticoagulation, you scope them, and certainly if you identify a source and you treat the source, then we restart the Coumadin, and if they don't bleed, then we send them back home and let their Coumadin come back up. If you don't find a source of bleeding, then we leave them in the hospital and you observe them until their Coumadin gets back up to therapeutic and you see if they start bleeding again. But almost everybody who comes in with a GI bleed ends up going home on Coumadin, with rare exceptions, the patients who really have refractory GI bleeding. And I think those patients that just can't be anticoagulated, you just try and transplant them as soon as you can.
That's a great question, and certainly an issue we deal with. Now, thank you very much, our panel, and thank you all our participants for your questions. We're now going to break for setting up the luncheon.